So for Henry Allen, I was curious how the DOJ was effective in preventing some mergers early on, but now we've got these big mergers taking place. What's changed?
Well, um, the DOJ has not had a chance to opine on the Aetna proposed acquisition of Humana, and that merger was announced on, I think, July 1st or July 3rd, and so I would, I would expect that this, given the politics of the Affordable Care Act, meaning that everyone has had high hopes for introducing competition into health insurance markets. That's the philosophy of the exchanges, that the DOJ will take a hard look at this merger. So, what has, as I said in my remarks, what really has changed is over the years is that we realize that market shares in health insurance are durable. Once a merger occurs, and if it results in market power, the antitrust laws will then be ineffective in policing this merger. So the incentive is there for them to really buckle down and come to an analysis. The other thing that's changed is that the government in recent years has gone to the AMA and to others in the provider community and obtained our views. So if in your community, if you are concerned about any of these prospective mergers, you should let your communicate your views to your, I would suggest, the appropriate professional society, including the AMA.
Yes or no, will they block it?
Will they block it? I thank you for fleshing me out on this. I'm not prepared to say. Sorry.
Thank you. I have a question for you that is along the lines of my prior question, and that is I spent the last 20 years in Indiana, and I saw Indiana Blue Cross and Blue Shield grow from a single Blue Cross and Blue Shield plan to Anthem. Okay, which it's sort of ironic that Indiana Blue Cross and Blue Shield is buying New York Blue Cross and Blue Shield and California Blue Cross and Blue Shield. But they recognized the opportunities at the right time. The question I have is that given that it's hard to merge not-for-profits, given the regulations involved, and that in general state legislatures had to facilitate the transition from a not-for-profit to a for-profit situation, what happened to allow Indiana Blue Cross and Blue Shield in all these states to consolidate what were existing Blue Cross and Blue Shield plans into Anthem and consolidate essentially the entire Blue Cross and Blue Shield marketplace, with the exception of some few states, into a for-profit entity?
Okay. The fact that that an organization is nonprofit is irrelevant to the antitrust analysis. The antitrust analysis is this thing. Oh, yeah. So you're asking me what happened? How did it happen? How did it? I can't answer that. I'm sorry. I don't know. Thanks for the question.
So, Michael, this is a question to you. We're in the process, as I'm sure many people in this room are, of a merger between a community hospital, local community hospital, and an academic medical center. And it seems that this merger and a lot of the others are driven by panic, that there's not a clear mission stated, certainly not to the the medical staff on either institution, both of whom are scratching their heads. And I wondered whether you, looking retrospectively at your acquisition of a community hospital while at Penn, what you learned from that, would you have done that again? What was the imperative at the time?
So I think if I were to reflect back, if there was a circumstance where it was clear that the medical staffs were never going to figure out ways that we could create some synergy with one another, and actually it was going to become antagonistic, we probably wouldn't move forward. Although I would also portend that it's rare where there's no opportunities to create some synergies. And so not knowing the specific, the specifics about the individual market. I do think that that clear vision of what are we trying to accomplish, and I agree with you 100%, I think this is true across the country right now, is there is a race to consolidate. And a lot of it has to do with, it's the scare tactics that's coming out of a number of consulting organizations, the legal issues, Henry talked about. I think there's a number of concerns that these aren't going to be clinically integrated networks unless they're on a common bottom line.
Maybe it will help if I explain it's Penn State, where Geisinger has just moved in. So Geisinger has just moved into a hospital across the river. Penn has acquired Lancaster, and we're panicking. That's the impression that I have. That the reason why we're doing this is because otherwise we're going to be swallowed.
Can I follow that? That's a very common reason across all industries. I think you're absolutely right. I mean, there's this charge into it. Managed care did it, all during the 90s. I think that's what you probably were referring to, how the flurry of mergers and all that stuff was. Right. But across all, it could be computer chip companies, it could be airlines. Look at the merger. Panic is a real thing, and the lemming behavior is unbelievable out there. And what has just been Mike pointed out about consulting firms. They make the same consulting firms around with the same message, and people come out with it. So panic's a real and irrational behavior, not well thought out, is not, shall we say, unusual attribute.
Those same consulting firms will unravel those deals too. They'll come back and charge you again. I think, well, that's what I was going to say, was now knowing you were, I think one of the where I would start is why didn't, not that for to answer here, but as a team, why didn't the merger with Geisinger work? And what makes you think that this would work any differently? And the lessons learned from failures, I don't think we do enough. And really sort of get to the front of the mindset of why didn't it work? Was it us that did, because it didn't work? And be really reflective around it. Because sometimes that gives a lot of insight to, I know from the Penn experience, the reason the first one didn't work for Penn wasn't actually the other organization, it was Penn and the way that we approached it. And so sometimes you really have to be reflective of it.
Okay, so, I as the flurry of activity continues in the hospital merger area, I encourage all of you to communicate with, your society. Try to get this known to the Federal Trade Commission if you see a problem, because the FTC, which is the agency primarily doing the hospital integration, although the DOJ also has jurisdiction, the FTC is really interested in the views of consumers. And you are seen as a proxy for patients. And if you perceive that as a result of this merger, your choice in the marketplace for healthcare is going to be impacted in a significant way, the government is going to want to, the government should respond. And the government has over the, after losing a whole bunch of cases in the 90s, the merger cases, because frankly, courts were very sympathetic to hospitals being not-for-profit, hard to see that a hospital board comprised of consumers would ever want to hurt consumers. After those mergers, the government did a retrospective study of what the effect in the marketplace was, and they found out, lo and behold, that healthcare prices had gone up in ways that can only be explained by the merger, and there was, significant impairment of choice in the marketplace. So after that retrospective study, the government went back in recent years, over the last decade or so, in challenging hospital mergers, and they've won maybe 6 or 7 cases in a row that where the government had in litigation said that the markets were very, very narrow, and the courts have been sympathetic. So there's real hope, of policing this trend.
So I just would address this to anybody that feels comfortable answering it, but with the consolidation of hospitals and acquisition within systems, what is the current state and what is the future for systems offering their own insurance plans to cut out the middleman? And, because I know Hopkins, MedStar, Penn, a lot of these places are doing it.
Well, we can talk to it briefly. In pediatrics, it's harder to take on that kind of role because sometimes you don't get organizations paying attention enough. So, but we did look into it, and I think part of it is the question of whether you're ready to make that investment. It's a huge investment in infrastructure, and there's an argument to be said that why should you make that investment if you can hire or go through another organization. So part of it is, but yet if you're doing it and it's your own, you still have to put up that money. So I think it depends on the market. So here again, we haven't gotten into the capitation so much, and so you're not going to want to spend that much. At the same time, we look at organizations here like Advocate, for example, that has at the very least put in infrastructure to help manage the care in that way a little bit more, and it's taking on risk. And they are ahead of the game, but they can only go so far if payers and other things aren't jumping on board. So.
That's a great question, and the answer is sort of complicated. First off, starting an insurance company is tough. I mean, it takes expertise, and I think one of the predictable outcomes of the Accountable Care Act is the fact that there were these community-based. Some people just start. They're all going bankrupt. I mean, they're just dying, and as you could have totally predicted that. And a lot of the earlier efforts of provider-run insurance companies way back in the 90s failed also, but there are some huge successes. Intermountain Healthcare is raring success. You mentioned Advocate. Geisinger itself is a plan. So my feeling is that there is a very real role for these in the future. If it can be done, get the expertise, there are no fantasies about how simple it could be. But Intermountain's exciting. I speak out there a couple times a year. Increasingly, the hospital system is delegating more and more leadership authority to the physicians. And they're passing the risk further and further on to the physicians. And it's working. They are lowering their costs very dramatically. So I think if an institution does it, the role of the physician is critical. And one of the reasons I think when Mike was speaking, or Henry, you kept asking why physicians know more about this stuff. This is what you do. That's why these focus factories might work. You know what the processes are. And it makes eminent sense that people know what the job is. They're going to do a better job of doing that job than somebody else who doesn't know. A better job at managing better outcomes.
One thing that I would add and underscore maybe is market by market is going to make a difference. So in a market where, the number one payer, and I'll use Chicago as an example, is Blue Cross, the competitive issues around going head to head to compete with Blue Cross are going to be difficult. And it's going to get viewed that way from a provider, where you're relying on it. The person sitting next to you, I think, from a UPMC could probably tell you over a couple of years some stories about what was going on between UPMC and Highmark, and the national news that had just sort of going to throes over that, and you already had an insurance product in a way. but, and you were the big provider in the market, so there was some protection in a sense, and it was still, it was warfare. So I do think there's a lot of things to consider before jumping into the insurance market. It's a difficult market to begin with, period, but
The reason I say is the three big players in DC, Nova, Hopkins, and Mets are all, Hopkins has a plan, I believe, yeah, all have plans. Maybe in Medicaid, Affordable Care Act flavor, but potentially expanding.
And so if you had a DC metropolitan area where maybe 85–90% of people were going to, you know, 3 systems, the systems potentially could take control of the market, I would think, and that's what I guess I'm asking. It's different for an isolated children's or in a city where there's maybe like 8 or 9 different systems, but I guess was wondering what the potential would be.
I would put one other spin on what you just asked, because I think it's a little bit different than do you develop an insurance product or company or not. It may be a product that is a more narrow network product, and I think there's going to be a lot of it. There's going to be a lot of experimentation there, you know, in the sense of it may be through a Blue Cross or through a Kaiser or somebody, not a Kaiser, but somebody else, where it is a narrow network and it's going to be managed, and the risk is going to get managed by that local network. I think we're going to see a lot of that experimentation around the country. The last time we tried it, it wasn't very successful, but you know, we are an insane group.
Real quick, people in the back here have been very patient. I think we need to give them some time. Okay, there you go.
I learned my lesson not to sit in the back row. So, and I think she's next. I'm from the Cleveland Clinic, and when we've been looking down these, care paths and value-based medicine versus volume-based, and to me, it's all a matter of timing too. And we cannot predict the timing. So we got one foot in one bucket and another foot in another bucket. And this is really to Dr. Hughes, because he's been looking at this for 30 years, and as a strategist, how do you play that out? And in the face of the presidential elections coming and all that, strategy-wise, what would you do, and how would you transition that? Because to me, it's a slow transition. It may accelerate, it may slow down, it may reverse.
What is the that? Into value-based care, from volume into value-based care.
That's a tough question. I mean, I think my colleagues would be more into that than I'm a macro guy overall, but I think it's done on a step-by-step basis. It's highly experiential, very incremental. I think you start small, you get your physicians working, and Pittsburgh, you're going to joke, yeah. So I think you start small, you start with humble aspirations, you have realistic expectations, you get everybody working together, and you develop creative plans. I mean,
even with Intermountain Health, we've been out there, they only have 50, service value-based lines. I mean, it's not that much, and there's thousands that you could create. So
the thing is to me, it's still the timing, because it's so unpredictable, and we're still incentivized by volume-based, whether we like it or not.
Regarding timing is one of them. You just got to keep a whole bunch of irons in the fire. No one really knows what is going to happen. My own bias is the president election is not going to end up with much in the way of significant change, but you just got to have every iron in the fire just in case this would happen or whatever. But Joe wants to, do you want to say something?
So handing it over, I'll say one thing that I heard from a consulting, and I don't necessarily put a lot of credence in some of these consulting firms, but McKinsey had them do some work for us, and their point was you got to think of this in a no regrets way when you're going through market change like this, because we don't know where it's going to wind up. So if you make these big investments where you may say, boy, I'm really going to regret that if it doesn't go the way everybody's saying it's going to go, because you can pretty be certain that it's not going to go exactly the way everybody's saying it's going to go today. It may be a different pace, it may wind up there eventually, but really starting to think about how do you start to develop competencies today that are going to be good, they're going to improve quality no matter what, but develop those competencies that can then get triggered down the road without going in full, both feet, so to speak, to use your analogy.
I was
talking with a couple of you about giving an example about this. So UPMC, I was just at a meeting with the hospital and the insurance company and the medical school or the department chairs. So it's a $12 billion annual budget, and this year is the first time where $6 billion is insurance. So you had the head of the insurance company there basically saying, you will make more money if you don't operate. And then we have the head of the hospital system saying, well, we're still getting money based on that. So we'll operate on other people's patients, but UPMC's patients will try to. So it wasn't that cynical, but that was the sort of the tension in the room. So an example of value-based care is we're considering now when a patient's admitted to have a frailty index. And if a 95-year-old, and this with the ortho chair brought this up, what do you do with the 95-year-old person who has a C1 and 2 problem, where we know surgery is not a great example, but you get paid to do it. So you have a frailty index where when that person gets admitted, they immediately have a consult with palliative care, a surgeon, an anesthesiologist, a critical care doc who comes and talks to the family and the patient and really says, listen, here, we have these statistics. There's a 95% chance you won't survive this operation. If you want it, we'll do it. But if you talk to patients about that and provide that kind of value, then we won't be spending 80% of healthcare on 10%, the last 2 years of your life. So that's just one. And when you're paying for it, when UPMC is paying for it and providing it, then value is very important.
So, yeah,
and it really is quality of
Joe,
care.
Don't you think shared decision making like that's still driven by who's the front line having that discussion and the incentives of those people having that discussion?
Absolutely.
It's so.
The surgeon talks first.
Exactly. It's
Right.
Mike's point about
like
it reminds me of
Yeah.
incentives is the key. And they're so disaligned, they're so unaligned, and that's a toughie. And I like your point about the winners and losers. There's going to be losers, and so how do you reduce the degree of loss? And that's brilliant. And the extent to which we can create, I hate the term win-win, but more so a mutually positive outcomes, the better off we are.
Just to remember, I want to respect everyone's time, so let's try to have maybe 3 more questions. So I know Deborah was waiting to ask.
My question is, as administrative costs for regulation increase, or as you mentioned, overhead kind of stays steady, and reimbursements go down, where do you see future revenue streams for academic medical centers? I mean, you can only acquire and merge with so many systems.
Teeth whitening.
Well, I think, I was going to say before you said you can only merge with so many, I think that that is what's driving more mergers. And I mean, even organizations that would never have considered it are saying, I can't grow more on our own, and I can't, because of the region that I'm in or locked into something, and I can't cut costs further. So that's the only way to do it. Beyond that, no, I think it's larger and larger mergers. I think that's really what it is, and not mergers per se, but other ways of expanding your range of value while still maintaining your culture. Now, you can get into urgent care, you can get into surgical sites, but you can only do that so much. Also, with a demographic that may not be growing in your.
So functionally, what you see in 10 years is functional socialized medicine, because you will have 1 or 2 insurance companies to choose from and 1 or 2 hospitals.
Yeah, I think here in Chicago, it's not going to be 1 or 2. It'll still be 5 or to 7. So it's going to be plenty here in the Chicago area because there's still a lot more there to do. But Deborah's going to talk more about it.
I think in some way, if I were to pull out a crystal ball, which means it'll definitely be wrong, I think there's going to be less hospital beds. I mean, there's just going to be less hospitals. There's going to have to be failures in the industry in order for us to get out of what we're in. because there's no way we're going to be able to fill all of these beds. And I think if there's a change in the migration and the advancement of technology, for the most part, has driven costs, not taking costs out, where in most other industries, technology has actually created some efficiencies, is we're taking those technologies and maybe using them in inefficient ways. And are there other efficient settings that we could be leveraging that technology? So do I think that there's going to be home surgeries? Probably not. But are there definitely alternative settings for things to occur other than an expensive institution? And we may become a cost center in a system of care where the most complex services are, and then we're going to have to think about what's the scale of that academic center. So if you were really to think 20 or 30 years down the road, there's some optimism that maybe we can, actually do things better and more efficiently. But it really requires a significant transformation of the industry. It's not going to happen unless there's an engagement of the people that want it to happen, in the sense which was sort of my underlying theory before. I do think from an academic center has a little other opportunities to start to think about revenue streams that we haven't thought about. I think tech transfer is a huge area of opportunity that many of us have underinvested in and haven't thought about. There's a lot of money in the economy right now looking for good investments. Have we really thought about our tech transfer processes in a way that would differentiate us? So from a clinical perspective, it may be there's going to be an enormous amount of change, but from an academic medical center perspective, I think we got to think of other ways that we can fulfill our missions, in a sense, and sustain one another.
There's a big lie out there. I mean, it's a fantasy. Delivering quality healthcare costs money. There's only going to be more and more products that are going to be delivered. The biotechnology industry will be coming out with a new drug a month almost now. And those are life-saving and life-enhancing drugs. And if you save somebody from having from cancer 5 years down the road, you get a stroke. I mean, think about the future. If you want to be a pessimist, it's all there for you. So this fantasy that somehow the cost can be eliminated is ridiculous. I mean, that it's a social choice issue. We can become more efficient, and we will dealing with end-of-life care, with this different payment mechanisms, aligning incentives. All of this will incrementally make us more efficient. But healthcare, even with that, instead of the rate of cost being, let's say, this high, it will be that slow. And this is called a social choice question. And I think what the medical society will ultimately decide what they want to spend their money on. I think most people, if given appropriate information, here's where we'd feel miserably, will make a decision to buy a healthcare experience rather than a new, iPhone 12. Okay, people make that decision. But we've got to get the word out, but the political notion that we can make the system X% efficient in some kind of a rapid fashion, it's ridiculous, and it's very destructive. And the only way they can cut costs is what my colleagues have found. They will keep cutting payments to providers. And your notion of socialized medicine, et cetera, right on. I mean, and I'm not a pessimist, but that's one of the scenarios, okay? I'm not so sure there will only be one or two insurance providers, but the government will keep pressing down. They have no other alternative. Particularly if you've got people saying we don't raise taxes, et cetera. Therefore, with people paying more of their own money for this and knowing what the value they're getting is a very important step forward. Just come back to Jack's market forces, et cetera. It's a tough future out there. And again, I'm an optimist, but it's going to be very difficult, very difficult.
I think we can do one more. We've had, Bob was asking.
Yeah, so let's have someone who's not asked. Yeah, let's, yeah. In the back, and then because these gentlemen have taken time from their families, so I don't want to extend their stay. Greg and Jack.
So we heard a lot of data by Mr. Allen about insurances are durable, they're either monopolistic or whatever it's called, and that pushes fees for physicians down, or it can. So my question to the panel is, what should physicians be doing about that? I mean, should we be investigating the process of balanced billing, opting out of contracts and being out of network, but then you can charge a higher fee? What other options are there for physicians? Because I feel like a lot of physicians, in order to keep their initial salary and revenue for a long time, just ramp up their volume. And I think we're at a point where you can't ramp up your volume continuously. You hit a ceiling, you can't produce anymore, but the reimbursements keep going down. And despite what hospital administrators say, there is a certain numbers game to this where you have to make money to pay your secretary, your salary, all these other things. So,
Target income theory,
Downgrade. Downgrade.
Oh, I thought you said Henry, so I was relaxed. I think Henry, I was very impressed. First of all, at every session like this that one does as a speaker, you learn a lot. I was very impressed by your point that the government will listen to physicians if they think that something being anti-competitive, one will hurt physicians. And I was also impressed that the assumption is made that driving down physician incomes translates into poor quality care for people.
I can't emphasize that enough. You know, you hear on the discussion of Aetna and Humana that one of the so-called efficiencies is that they are going to be able to gain leverage in negotiation with physicians. I don't, by the way, but I don't hear Mark Bertolini at Aetna saying that, because he knows that the government is going to say, oh, if that's what you're going to do, look at all of the cases that we've filed where we've challenged mergers, pointing out the harm that you can do to physician marketplaces. So that's not the kind of efficiency that's going to save that merger. So that brings it back to what do? You talk to the government, and then if there are practices like if they have market power in one product line and they try to force you to take a second product, that could be a tying violation. You talk to your medical society, you talk to lawyers.
but the government's doing the same thing with the Affordable Care Act, Medicaid, and Medicare, is they set the prices, and then everyone says, well, we're 120% above Medicaid. If Medicaid's paying me 2 cents, I'm getting 2 cents and next to nothing still. The government still regulates the market by setting what the bottom line, and everyone moves from the bottom line up. But the government keeps lowering the bottom line, just like the insurance companies are. They're in a monopolistic manner as well.
They're squeezing you.
Yeah.
And this will continue. And that's why it's very difficult. Listen, the physician is critically important. The healthcare system cannot exist without physicians. In certain industries, we can kind of squeeze out certain types of technology. The iPhone components or the iWatch, over time, certain things will be squeezed out and certain things will come in and be more efficient. You cannot have a health system without physicians. And the government knows that, and so the only way they're going to deal with the problem is they're going to try to pay them less and less and less. You just got to fight back. By the way, the job description of this society, okay, we've got a VP of Communications, okay, should be speaking to every Rotary group in the country, you speak every Kiwanis club, every PTA in the nation, okay, and the second most closest thing to the Communist Party in the United States, the AARP. Okay? All of these, the message has to be given, and basically it's a dose-response curve. It's basically message, 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 message. It's not one day in Springfield, Illinois, or what else, just saying, hi there, Congressman, we want you to be more, benevolent to physicians. You've got to be involved and involved and involved. Okay? Toby Cosgrove, he's involved in this. And you've come from a great institution. So you've got to do it. You've got to fight back. Because otherwise they will press you and press you and press you.
But even he agrees that physician salaries will be depressed.
Oh, yes. Yeah. But you got to fight back. You've got to fight back.
But not his.
Yeah. Well, that's another issue. I think that's another issue. And we see this in the university, where administrative salaries are going up like this, and faculty, if they're going up all, that's an issue that has to be addressed. I think with that.
I think we have one more question. You guys can. Who goes first? All right. You go first.
Thank you.
And you guys, once it's over, you obviously have.
I want to follow up on that. The question is directed to the CFO. Along that line, our production is being measured. How many patients seen? How many surgery done? How many RVU? Question to you is, how do we measure administrators' output?
And I want to comment also before, but administrative output is whether we have the resources to invest in all the things tomorrow that haven't even come up yet. So, I mean, we have to be able to, have those dollars for the next technology, because otherwise we won't keep up. What I wanted to point out, though, and the same thing goes for the administration and pushing back on governments that are reducing payments, is you have to make yourself invaluable. So that gets to the raising the cost because there's more specialties and specialists and even more, of that. But frankly, that's the way you do it, because you say you can't live without me. You might say that you could reduce the number of providers that are providing, the removal of a wart, but you can't reduce the number of providers that are, fixing a kid that's got a cleft palate, right, and needs that type of care and can't get it anywhere else. So I think by keeping those pieces alive and, continuing to grow your practice into specialties where you're invaluable, you can call up the government and you can say, you can't do without me. You can call up the managed care company and say, you can't do without me. You don't even need scope for that. You can just specialize in that one thing and say, you can't live without
it. I would add maybe one or two other comments. From an administrative productivity perspective, I think we do have a responsibility to try to figure out ways that we can reduce administrative costs too. It's not just clinical productivity. It's, there are some administrative issues that we need to create more lean processes and think about other ways that we can create organizations. But I also think we need to think about how do we engage one another, because there is waste in the system. We get in the way of ourselves. We create it sometimes. And I think that's how do we create the right forums and opportunities for us to go after those sorts of things. To the productivity of physicians side, I've actually been thinking about a lot of this. I'm getting some strange looks right now within Rush. Does anybody know who Quint Studer is? He started the Studer Group. He's done a lot of work in terms of balanced scorecards and how do you sort of move things across an organization. I've been through a couple of sessions with him now, he's trying to think through, and I'm jumping on the bandwagon of if there was a way we could eradicate RVUs from physician productivity measures, because I hear more often than not that all physicians see is that they're an RVU machine, and that's not what the physician industry and what the physician profession is meant to do, right? So I'm preaching to the choir here, I know. But a lot of our compensation structures are built off of that because you can measure it. And you need to build a compensation. If you're going to look at productivity, you got to have something that you can measure, I guess. We're looking hard at, is there some other way that we can measure that and get rid of RVUs? Because physician engagement is as important as employee engagement is, in a sense. And so I don't know the answer to it yet, but I think we got to solve it. Because I don't think, certainly if you talk to patients or the average consumer about those sorts of things, they don't care how many RVUs their physician generates, right? I mean, it's the personal relationships and the optimist in me when I think about the changes maybe ahead of us in healthcare is if we can get to a point where it's not just about more procedures and more fee-for-service and cranking out more RVUs and really starting to act in a way that's smarter, that provides a really great product for as efficient as we can, and maybe it's not going to be as efficient as some of us would like to see on a macro basis. That's what's ahead of us if we can figure it out. I mean, that's what we got to try to figure out together. But it's not going to be the administrators figuring it out without the physicians. It's probably not going to be the physicians figuring it out without the administrators. We've got to get together and figure something out, because where we're headed right now is, while very humorous, sadly, is exactly what Dr. Hughes is talking about. It's just the costs are just going to continue to go up. Everybody's just going to get paid less, and eventually, something will break. But it's not a pleasant outlook if you think about it from that perspective.
On that upbeat note.
So, yeah, I want to thank all the panelists for taking their time, all of you for your great questions, and it shows that there's enough interest that we can figure out some way to continue this in the future, but thank you for participating. For those of you who want to go with Robin, Robin is going to give a tour. Yes, why don't we do that?
We'll do a quick photograph, and then after that, lunch is back at the Mile North. And whoever had left their suitcase this morning in the breakfast room, remember it's right over here.